Always put on your mask prior to scrubbing. The soap and sponge combination are then opened, and a nail cleaner is typically enclosed. The fingernails are cleaned with the nail cleaner. The water is turned on either by an automatic switch or a foot or leg switch. Both arms are wetted up to the elbows, and the foam is formed on the brush. The fingernails are first cleansed, then between the fingers and each finger, scrub assiduously. The scrub is then carried further up the hands and arms. The scrub should be carried up to the level of the elbow and no higher. The other hand is then done in the same fashion, with care to clean all sides of the fingers, between the fingers, the hands, the wrists, the forearms, up to and including the elbows. The sponge is discarded and the hands are rinsed first. The arms are then rinsed, with them being held upright so that the water runs back towards the elbow and not towards the hands and arms. The hands are held upright so that the water continues to drip off the elbows. One arm is then dried from the fingers and hands toward the forearm and elbow. The towel is then turned and grasped in the clean area, and the same is done to dry the opposite hand and arm. Care is taken to never dry back from the unsterile elbow region back towards the clean, sterile hands. The gown is held up and the arms are inserted. The sterile assistant pulls the gown sleeves so that the hands become exposed. The gloves are then held open by the assistant for sterile entry. Utilizing the first gloved hand, the surgeon can assist the placement of the second glove. A circulating nurse then snaps the gown up for the surgeon. The sterile tie-around or snap can be done either by the surgeon themselves or by the assistant to preserve sterility. Occasionally, one will have to dry and glove without assistance. Again, the towel is grasped with the arms and hands dried in the usual fashion. The sterile glove pack is then opened, as the inner package is sterile as well. The two gloves are grasped on the inside of the folded cuff, and the first glove is placed onto the hand. The sterile fingers of the gloved hand can then be utilized to pull out the second glove and help to support it so that the second hand can enter easily. This type of gloving is typically used in emergency room settings for simple procedures like laceration closures. The scalpel. This instrument is most synonymous with the surgeon. It is composed of a scalpel blade and a scalpel handle. Scalpels are used to make incisions in the skin or other deeper structures when a fine and precise cut is required. Scalpel blades can be used to separate or dissect various types of tissue. Scalpel blades come in multiple shapes and sizes. The two most common blades are the number 10 and the number 15. The number 10 blade is a large knife blade used for incisions on the scalp and the body. The number 15 blade is a smaller knife blade. It is typically used for facial surgery. The belly of the blade is the cutting edge. The scalpel handle is held like a steak knife. The index finger guides the blade while the handle is held between the middle finger and the thumb in the palm of the hand. The number 15 scalpel handle is held like a pencil. An incision is started by stabbing the tip of the blade into the skin. Then the knife handle is rotated backwards so that the cutting belly of the blade is held at approximately a 45-degree angle to the skin surface during the incision. When loading a scalpel blade onto a scalpel handle, it should always be grasped with either a clamp or a needle driver, and then the blade should be slid on. The same is true for removing blades. It should be lifted up posteriorly and advanced forward and then pulled off. This is to prevent injuries with the scalpel blade. Tissue scissors, also termed dissection scissors or undermining scissors. These tissue scissors are used to dissect or separate the tissues. This elevation or separation of the tissues is called undermining. Many tissue scissors are curved at the cutting edge. If they are curved at the cutting edge, it is usually best to dissect and undermine with the curved tips upward, so you can visualize exactly what is being cut. Dissection scissors usually have the tips that are either partially blunted or fully blunted. This is to prevent penetration of the structures beyond the surgeon's view. In this example on a pig's foot, the tissue scissors are usually pointed upward towards the skin surface in order to prevent injury to the deeper structures. When dissecting with tissue scissors, it's appropriate to have tension and counter tension on the wound edges in order to allow precise undermining. The forceps is used to grasp or to retract or to stabilize tissue. Various types of forceps instruments are available. They come either with no teeth, a single tooth, or multiple teeth at the end of the instrument. Various tooth sizes are used depending upon the size and nature of the tissues to be handled. The forceps is grasped between the thumb and middle finger, while the index finger is used for stabilization. If possible, when operating on skin, use forceps to grasp the dermis, that tissue just below the surface, rather than the epidermis or skin surface itself. This grasping of the dermis helps to prevent marking and injuring of the skin at the wound edge with the forceps. Skin hooks are used for pulling, also called retracting the tissues. Retracting allows you to see the deeper tissues and also puts the tissues on tension, which can help in the surgical dissection when you use either a knife or tissue scissors. Most skin hooks have small, sharp prongs that hook into the dermis. This prevents trauma to the epidermis or skin during the wound retraction. The skin hooks are placed and retraction is done by grasping the instrument between the thumb and index finger. The third finger or middle finger can stabilize the hook, and the fourth finger can be used to place counter traction on the tissue just beyond the skin hook for better visibility and easier dissection. The retractor is a blunt instrument used to pull tissues out of the way so you can see better. They come in all shapes and sizes. Some are even self-retaining. Pulling the tissue in one direction is called traction. Pulling the tissue in the opposite direction is called countertraction. This can be accomplished with either an instrument or with finger traction. The needle holder is the instrument used for placing sutures. Actually, the needle holder can also be called a needle driver. It holds the needle and pushes or drives the needle with the attached suture through the tissues. The needle holder is held in the palm between the thumb and fourth finger in the holes of the handle. The second finger, or index finger, is utilized to stabilize the direction of the needle holder's end. The third finger is placed against the ring with the fourth finger, and that's also used to stabilize the instrument. The needle, with its attached suture, is usually grasped in the jaws of the needle holder, so that approximately 2/3 of the needle is on the cutting side and 1/3 of the needle is on the suture side in the jaws of the needle holder. This allows for stabilization of the needle and helps prevent bending of the needle. Needle holders may have several varieties of jaws. The first are jaws with teeth. These contain particles such as tungsten carbide, and this allows for needle stability and prevents rotation or slipping of the needle while in the jaws of the needle holder. Second are smooth jaws without teeth. A smooth, fine-jawed needle holder can be used with fine needles. The needle holder can be used to tie and to knot sutures. Do not use a hemostat as a needle holder. Hemostat jaws are not designed to properly hold the needle and may in fact damage the needle. The needle must be placed perpendicular to the skin edge so that the needle holder can drive the needle with its attached suture through the tissues on the curved trajectory that follows the curve of the needle. This approach places the needle and the suture in a manner so that the edges of the wound are both approximated and everted when the knot is finally tied down. The hemostat is a clamp designed to grasp blood vessels prior to cauterization or ligation of those blood vessels. The hemostat is held much like a needle holder. When clamping a blood vessel to stop bleeding, you should clamp just the blood vessel and avoid clamping excessive surrounding tissue. A blood vessel is clamped with the curved tips of the two hemostats facing each other. The vessel is then cut between the hemostats in preparation to tying the vessel. Suction instruments. There are various suction instruments that can be used to remove fluids and blood from the surgical field. The suction can be either continuous, while some others are intermittent. The intermittent suctions have a side porthole which can be plugged or occluded, which allows the suction effect to occur. When the side porthole is unplugged, the suction is turned off. Cautery comes in both monopolar and bipolar electrical current. The electrical current coagulates the blood vessels to stop the bleeding. The monopolar current can be used to both coagulate and to cut tissues. The skin is rarely incised with the cautery. Occasionally, the cautery will be used to incise and cauterize the deeper tissues for speed of operation and for hemostasis. The monopolar cautery generates more heat than the bipolar cautery. Some cauteries are disposable and some are non-disposable. The non-disposable monopolar cautery has a cutting and cauterizing button. Disposable monopolar cauteries are available for one-time use only. You can press the button to activate the cautery. Bipolar cautery is a cautery with two poles, one on each side of a forceps-like instrument. The tissue that is grasped in the forceps of the bipolar cautery is the tissue that is cauterized. This results in less transmission of heat to the surrounding tissues. A foot pedal is used to activate the bipolar cautery. Bipolar cautery coagulates the blood vessels or the tissue between the tips of these special forceps. The suture scissors are probably the first instrument that you will use in your surgical experience. Suture scissors obviously come in various types and models. They are made to cut suture. Tissue scissors should not be used as suture scissors, as this will dull the instrument. The size of the suture scissors should be compatible with the size of the suture to be cut. The assistant almost always cuts suture. Skin sutures are usually cut with approximately a 3 to 4 millimeter tail for easier removal after healing. Always ask the surgeon the desired length of suture tail before cutting, and the tail is the amount of suture that's left above the knot. When a tail is to be left behind, especially on skin sutures, slide the scissors down the suture to the approximate tail length, turn, and then cut. This turning of the scissors allows the surgical assistant to visualize the knot and the amount of tail that will be left behind. Usually, an appropriate tail length for skin sutures is about 3 to 4 millimeters. Why is a tail left? Leaving a 3 to 4 millimeter suture tail helps prevent loosening and/or undoing of the sutures. Sutures that are buried are left within the body. These sutures are usually cut on the knot. Cutting on the knot cuts the tails off the ends of the suture. To accomplish this, you slide the suture scissors down the suture until the knot is felt just under the blades of the suture scissors. Then the scissors are turned slightly and the cut is flush on the knot. Always ask the surgeon the desired length of suture tail before cutting. Towel clip. This instrument is used to fix sterile drapes into position. The towel clips come in two varieties. One is much like a normal clamp and is placed like a hemostat in the illustration above. The other type, not shown, is called the bulldog and is grasped between the thumb and index finger and then allowed to automatically close on its own. During the draping of the patient to prepare the surgical field, these drapes are held in place with either a suture or more frequently with towel clips. The staple gun. The handheld disposable staple gun is used to apply metal staples to close the skin. This is especially useful for rapid closure of scalp wounds. Staples are never used in the face. The two-handed tie is begun by looping the left hand below the green string, and the right hand brings the yellow string closer to the thumb of the left hand. The yellow string is then brought down over the green string on the thumb of the left hand, and thus an X is made. The right hand then puts tension on the yellow string, and the index finger of the left hand goes through the loop, and the right hand then rotates the yellow string to the thumb and index finger of the left hand, which captures the string. The right hand is released, and the left hand pushes the yellow string through the loop. The free end is now again grasped with the right hand. The hands are slightly crossed, and the throw is secured down so that the knot lies flat. Notice the difference between the square knot and surgeon's knot. In the first throw, notice the difference between the square knot and surgeon's knot. In the first throw, there is one loop in the square knot. In the surgeon's knot, there are two loops in the first throw. That is the main distinction between the two knots. The two loops of the surgeon's knot are designed to prevent slippage of the first throw. Instrument tie the surgeon's knot. The instrument tie in this example will be the creation of a surgeon's knot using the needle holder. The wound is closed with one interrupted suture, passing through one edge of the wound and then through the second edge of the wound. The left hand then picks up the green string and wraps the suture around the needle holder. Two loops are carried around the needle holder. The yellow free edge is grasped with the needle holder and pulled through both green loops. This throw is then